Hello, everyone, and welcome to another audio podcast in this series around the Busta Cap episode. So far in this episode, we've talked about the definition of blood and hemopoiesis. We've talked about the use of red blood cells. We've talked about the use of platelets and granulocytes. And today, I'm going to give an overview on the use of human albumin solution. Now, human albumin solution, or has, is important in particular conditions, but also under particular scenarios. And basically, I'm going to give an overview of how human albumin solution is prescribed and issued from a hematological and transfusion practice perspective. I am your host again, the Shientist, and this is another Storm Lobostics production. So, human albumin solution, or has, is produced is produced from large pools of human plasma by cold ethanol fractionation. Now, in addition, the final product, i.e., again has, is sterilized by filtration and pasteurized at 60 degrees centigrade or Celsius, sorry, for up to 10 hours. Has is supplied to laboratories, transfusion laboratories, basically where they are after being fractionated, where they're after being fractionated from screened donors, and where the plasma is screened from donors. Now, these donors are particularly selected from countries where there is no known cases of something known as variant CJD. And CJD is a form of disease that can cause complications to hematological parameters, and I'll talk about this not so much in this particular audio podcast, but I will talk about CJD in another series or episode prospectively. Now, has generally is prescribed or supplied, I should say, in various quantities. Now, in this slide, I'm highlighting where has 4.5%, retrospectively or historically, was known as Zenalb, which is basically the brand name for has, or human albumin solution. Now there is a different formulation, or generally speaking, from different manufacturers or pharmaceuticals, but historically has 4.5% has been known and issued as Zenalb 4.5, and it's supplied in 500 ml quantities, 250 ml quantities, 100 ml quantities, and 50 ml quantities. Generally, the human albumin solution looks like this, and there's a picture here, or an image here, basically, of how human albumin solution looks. It is in basically in a bottle. And basically this image, the image shows that this is supplied from Baxter, a pharmaceutical company known as Baxter. Now has 20% or Zenalb 20 is supplied in 500 in 100 ml, 50 ml, and 5 ml quantities. So again, in this image, there's a picture of what Zenalb 20 looks like, or 20% looks like. Now, greater than 95% of protein content is albumin, and generally from a physiological perspective, the largest protein within the body is albumin. Now, generally, also there are no coagulation factors or what are known as immunoglobulins in the product within albumin, or human albumin solution. The sodium content within has human albumin solution is also important, and there is generally a controlled amount of sodium. Sodium generally, where patients may require human albumin solution, may also require sodium, so that the electrolytes within physiological can be sort of balanced from a systemic and physiological perspective. So in line with this, I thought I provide this perspective in a table, and this table gives an approximate content of albumin and sodium in human albumin solution by volume. Now, there is so for example, human albumin solution 4.5% in a 500 ml volume gives up to 20 to 25 grams of albumin, and less than 80 millimoles of sodium. Has 4.5% at 250 ml volume. Has an albumin quantity in grams and 10 to 12.5 grams, which is less than 40 mils per sodium. Millimoles per sodium. And then has 4.5%, 100 ml volume has up to between 4 to 5 grams of albumin, and has just less than 60 millimoles millimoles of sodium, and then so on and so forth with regard to has human albumin solution 20%. Now, generally speaking, in regards to where albumin is needed and would be required, it would be down to the physicians and laboratory scientists collaborating to actually ensure that the patient who requires albumin solution, human albumin solution, actually have the appropriate prescription, so that the patient does not, for example, in a blunt way, I guess, does not die during a particular procedure. Now, there are other constituents. So basically has 4.5% and has 20%, have different amounts of content in relating to different sort of constituents, such as I mentioned sodium, but there's also potassium, there's chloride, there's citrate, and there's another derivative of sodium as well. And this table in here sort of highlights the constituents by has 4.5% and has 20% by the other constituents in regards to millimoles per liter. And generally speaking, again, depending on the scenario where an individual may require a human albumin solution, the physicians and laboratory scientists would collaborate to actually ensure that the patient gets either 4.5% or 20%, generally speaking. Storage is actually is between 2 degrees centigrade Celsius or centigrade and 25% in the carton. So the carton is basically the human albumin solution that comes in a bottle. That's in a bottle, stays in the carton, in the carton, and so that the product is normally kept in the dark, and it's not it's not meant to be kept under freezing sort of freezing conditions. 2 degrees centigrade Celsius is actually the minimum, and it should not be, for example, under freezing conditions, for example, minus 4, for example, -3, -2, etc. Generally, because when is required, human albumin solution is required. It is required post haste in patients who might have particular bleeding issues, for example. The shelf life of 4.5% human albumin solution when it's not unopened, where it's unopened, is, for example, 18 months. 18 months from production for human albumin solution that is in and around 50 and 100 ml quantities. 24 months from production for human albumin solution that is in 250 ml quantity, and up to 30 months from production, up to 30 months from production for quantities of 500 mils or 500 mils. Now, it's important that generally, as mentioned in relating to the previous slide around storage, it's also important to know that that human albumin solution, as soon as it's opened, it has to be used pretty much immediately, and in any case, the product should be infused within 3 hours. That's how important it is for physicians and laboratory scientists when looking to remedy a patient in relating to particular scenarios. How quickly it is important for the human albumin solution to be used. The shelf life for 20% human albumin solution is actually not all that different. It's 24 months from production, where the shelf life of 20% human albumin solution, wherein the quantity is between 50 and 100 mils, and it has to be opened. When it is opened, it has to be used within 3 hours. Some laboratories historically and historically, if, for example, the human albumin solution has been requested, and then, for example, along with human albumin solution, other blood components have been requested, and the blood components have been sort of used, then generally speaking, some physicians when they've requested, or once they've requested human albumin solution, find that the blood components can actually sustain the issue, a patient's particular health circumstance, and so what happens is that the human albumin solution may not be used. And so generally speaking, the guidelines around human albumin solution are actually now according to particular guidelines and what are known as standard operating procedures from laboratory practice are now actually more rigid now. So within once human albumin solution is opened, it has to be used within 3 hours. If it's not used within 3 hours, then basically it's actually deemed as not viable in laboratory, from a laboratory perspective. And so has human albumin solution is ready for the use, is normally ready for the use and the administration for intravenous infusion only. And if large volumes are administered, then has the human albumin solution should be warmed up to room and body temperature before use, so thus to ensure that the product, that human albumin solution, can actually have an appropriate efficacy as soon as it is sort of issued. So human albumin solution should not be mixed with other medicinal products such as whole blood or packed erythrocytes. And so what normally happens in critical situations where patients might require sort of other where in situations or scenarios, where patients may require sort of blood transfusion along with other blood components. Normally what happens is that blood components from a transfusion laboratory perspective are issued in a sequential way. So basically, for example, red cells might go out first if required, then platelets, for example, or platelets and red cells may go together if required, and then has human albumin solution may go after if required. Before that as well, cryoprecipitate may be required. So generally speaking, transfusion laboratories would release blood components and products according to a sort of a sequential way to ensure that the product ensure that the blood components etc. that had been requested are actually being requested and used at the same time, and not just be requesting where frontline health professionals, for example, are requesting blood components for the sake of just fulfilling what might be required when actually could end up being wasted and unused. So in patients with greatly reduced blood volume and or shock, the rate of infusion may be as rapid as necessary, and this, for example, could be anything from 1 liter per hour. So I'm going to just repeat this again. So in patients with greatly reduced blood volume and or shock, the rate of infusion may be as rapid as necessary. For example, anything from up to 1 hour 1 liter per hour. What this means is that based on where a patient or individuals might be bleeding out or hemorrhaging, and it could be for could be a number it could be for various reasons, reason why blood could be could be lost. But basically, red cells are, for example, as mentioned, are normally the blood components that are issued out first, as and when required. And what happens is that these are used based on the reduction in hemoglobin and blood volume and used. And so what health professionals on frontline do would actually ensure that patients are infused as quick as possible to replenish those red cells that are being lost through blood loss and hemorrhage, for example. And so in relating to this, as the patient improves, the rate should be adjusted according to the individual circumstances and the indication, but should not normally exceed 5 mils per minute or up to 300 mils per hour, because basically what happens is that the more blood that is actually that is used to remedy where there is blood loss, what can happen is the blood that is being used in anemic states, in sort of anemic situations, can actually through infusion can actually cause complications as well. So generally speaking, once the hemoglobin level or the titer around hemoglobin has gone from, for example, any hemoglobin level that is less than for example 8 according to laboratory practices, anything less than 8, or I think less than, in some laboratories, less than 7, then basically as soon as the hemoglobin is back to normal after infusion of red cells, then basically the blood and the circumstances should then be that the health professionals on the front line would inform laboratory scientists that for example there would be no need for any further blood, at least in circumstances where for example a hemorrhage has been evident, and where frontline health professionals may have a tendency to over prescribe, over request, and so if that's the case, then laboratory scientists, what they would do is pull back on some of those red cells that would be ready to be issued, along with other blood components. And so the rate should be adjusted accordingly to the individual and the for example, the type of bleeding condition or hemorrhage that might be going on. So in patients with greatly reduced blood volume under shock, again, the rate of infusion of 20% human albumin solution should not actually exceed anything above 120 mils per hour. This is very important actually, because what happens is human albumin solution, irrespective of whether it's 4.5% or 20%, and some pharmaceutical companies and organizations now have other different percentages around the concentration around in regards to human albumin solution. But what can happen, because of the components or the constituents that actually are within human albumin solution that relate to normal physiology, actually have a quick effect. The efficacy around 20% and even 4.5% tends to work quite quickly. And so again, it should not a human albumin solution again should not be should not exceed 120 mils per 120 mils per hour in relating to the rate of infusion of how human albumin solution is administered. So again, as the patient improves, the rate should be reduced to a recommended rate of 1 to 2 mils per minute, which is about 60 to 120 mils per hour. So standard operating procedures in laboratory and from a laboratory practice laboratory practice may differ slightly in some regard, but generally transfusion around human albumin solution is used in very sort of those scenarios and cases where patients are very prone to actually, for example, may sort of die without this form of treatment. Hence why physicians or frontline health professionals would actually look to ensure that other blood components are as part of normal physiology are replenished first, and has human albumin solution is used if and when absolutely vital. The dose of human albumin solution required, again, depends really upon the size of the patient as well, the severity of the trauma or the illness, and of course on the continuing fluid or protein loss. Now, generally speaking, human albumin solution is used where the main protein, that i.e. albumin, has been lost. Now, generally speaking, albumin has a very large molecular weight, and actually should not be lost through normal physiology. It is lost, however, in particular under particular sort of health issues. But when bleeding, where bleeding is concerned, what happens is that all sorts of constituents that make up physiology and biochemistry are generally lost or lost through, for example, a major hemorrhage, let's say, or a bleeding condition, for example, or for example, where in other known sort of traumatic conditions. So the measures of circulating volume and not only plasma albumin levels should be used actually to determine the dose required. Now it's normally again a collaboration or collaborative effort between those health professionals on the front line and laboratory scientists to actually work out the appropriate dose, work out some of the appropriate dosages in relating to hematology. However, on the patient's notes, there would be some indication as to whether the dose should be administered for example, at timed integers. And what this means is that, for example, for a typical patient, no matter the for example, no matter the demographics around that patient or those individuals, generally speaking, if a patient or where health professionals would know that for certain patients, generally speaking, if, for example, there is an overall prescription of human albumin solution to be used, however, at the same time, they know that human albumin solution cannot be administered in a large dose, irrespective again of whether it's 4.5% or 20% human albumin solution, where health professionals would look to request an overall volume of human albumin solution, and then at timed integers would prescribe an amount through infusion, and so generally measures again of circulating volume and again not only of plasma albumin levels are used according to appropriate dosing. So for an adult, assuming a plasma volume of 40 mils per kilogram, which is an approximation for adults, the albumin dose can be estimated from the following formula. So this is a typical example. So the target plasma albumin level minus the actual plasma albumin level multiplied by 0.08 and times the body weight in kilograms and equals the actual albumin required in grams. And generally speaking, again, the 4.5% human albumin solution and 20% human albumin solution would have an amount of albumin already within them, within the vials that are normally ready made. And believe it or not, in a time in a time before, human albumin solution used to be where laboratory scientists would make that up actually in transfusion laboratories in sort of in historical, from a historical perspective. But from a pharmaceutical or a pharmaceutics perspective, what happens now is that these vials are ready made as and when transfusion laboratories require them. And so what happens is that the target plasma albumin level minus the actual plasma albumin level multiplied by 0.08 multiplied by the body weight in kilograms equals the actual amount of albumin required, and the albumin required is already within the vials as mentioned. So in some regards, the albumin required is down to the health professional who might be who would be looking after a patient who may require albumin solution owing to particular procedures, etc. So 100 ml 20% human albumin solution retrospectively contains around 20 grams of albumin, and 500 mils of 4.5% human albumin solution contains around 25 grams of albumin. So I'm now going to jump on to talk about a little bit around the use of human albumin solution, and some of these things I have talked about, but I'm going to give this as a kind of an overview. So there's acute plasma volume replacement. So where, for example, 4.5% human albumin solution is effective as any colloid or hemocell hydroxyethanol starch or gelfusin, which is basically is where basically human albumin solution is used as an intravascular volume expander. So it actually helps to expand those expand and also to replenish those important components within blood volume, and also acts as a volume expander, so that patients who have this can respond quicker under sort of devastating sort of conditions. And these alternative colloids or crystalloids are, however, to be preferred in most situations, not least for cost, except when plasma volume is low due to increased oncotic pressure. 4.5% human albumin solution may be beneficial in the elderly. It may be beneficial in anaphylactic shock. It may be beneficial also in adult respiratory distress syndrome, and also in patients with sepsis. Plasma protein replacement in sort of burns related conditions have a formula that are devised for fluid replacement in burns cases. So, for example, the following formula was actually derived at the Mount Vernon Hospital based in Middlesex in the UK, in the burns unit, and this was where fluid replacement with 4.5% human albumin solution in the first 36 hours after the burn is given as follows, and that is where there's a percentage of body surface area that is burnt, that could be burnt, and multiplied by the weight in kilograms, and then times the times 0.5, which and then gives times by multiplied by 0.5 and gives the volume of 4.5% of human albumin solution required. Retrospectively, for each of the six time periods or durations, there is an amount of human albumin solution that can be used over those particular durations, retrospectively. There's also some context around treatment of what's known as diuretic resistant edema in hypoproteinaemic patients. Now, in patients with liver disease and something known as nephrotic syndrome, who tend to have edema, who may have edema where basically at the bottom of the ankles there's swelling, but in nephrotic syndrome, what happens is that the patient's edema is resistant to diuretic treatment. So normally diuretics in nephrotic patients are used to offset some of the edema. However, 20% human albumin solution followed by a bolus dose of a diuretic known as furosemide may produce a diuresis, which can then be maintained by smaller doses of diuretics alone. Now, generally in hypoproteinaemic patients, diuresis can be in some patients it can be problematic, because what happens is that more protein loss can occur through that. And what diuresis means is basically where the urine of an individual becomes more dilute. And so basically, for example, for example, over a typical day, having fluids or intaking fluids, what can happen is that the urine of the individual can become more dilute, which then triggers at the same time through physiology and also the central nervous system, can actually trigger the thirst center to thus drink more or take in more fluid. And then what happens alongside with that, unfortunately, and this occurs in patients or individuals who have nephrotic syndrome, but also has in those who have, for example, can have typically focal segmental glomerular sclerosis, which is another form of protein leaking type condition, can actually lose protein and particularly albumin through diuresis. And so this can be a problem, but in patients where there is evidence of edema, can actually be treated with diuretics and controlled. However, at the same time, human albumin solution in patients in such patients where they may have other particular conditions and under situations, for example, where they may be bleeding out, then human albumin solution can also be prescribed, but it would have to be again used or prescribed at sort of at an appropriate dosages, at appropriate dosages, respectively. So there's something else I'm going to talk about just briefly, and that is plasma, something known as plasmapheresis. I talked a little bit about in the previous sort of audio podcast about the use of platelets and granulocytes, and I mentioned a terminology known as apheresis, which is basically a pooling of platelets into one bag, so that patients who may require platelets in sort of situations that are required, basically where rather than where, for example, health professionals on the front line request a number of platelets or platelet bags, they can have they can request apheresis platelets, which would mean basically the platelets would come in one bag to make up a concentration that focuses on replenishing those platelet stores within physiology in around more quickly, rather than waiting on a request to fulfill sort of a platelets where generally speaking platelets would require sort of a timed amount of infusion, and instead of that happening, apheresis platelets come in sort of one bag in a pooled platelet bag, rather than having one platelet bag at a time. So plasmapheresis is different, and what this is basically in all situations except what is known as thrombotic thrombocytopenic purpura, or TTP. 4.5% human albumin solution has been recommended replacement fluid for plasma. So basically, where there is plasma loss, for example, in individuals where in conditions known as thrombotic thrombocytopenic purpura, or TTP, generally within plasma, as mentioned in one of the previous audios and podcasts around the definition of blood and hemopoiesis, generally plasma holds and contains all the other important components that help fight off infection, etc., etc. In patients with TTP, generally there's a lower platelet count, and generally 4.5% human albumin solution has been known to be used and sort of prescribed in individuals where plasma has known to be where there's been known to be a reduced volume of plasma. So it's important to know that plasmapheresis can be a sort of a way to remedy patients with sort of known TTP conditions. There's also something called parenthesis or parenthesis, and this is basically where it's used to replace massive protein loss in patients with conditions known as sort of cirrhosis or liver cirrhosis, and treated where protein loss is treated with repeated volumes of parenthesis. So 20% human albumin solution can be used, and 40 grams, around 200 mils, can be used for each liter of acetic fluid removed. Now, what I mean by acetic fluid is basically where if you so imagine for example, there is within general physiological and systemically, there is a volume of sort of toxin or waste that needs to be removed, that can be referred to acetic fluid. And basically, health professionals would look to would part of particular conditions known as cirrhosis. This acetic fluid can be removed before a patient is treated with human albumin solution, because again, the idea of having human albumin solution is to remedy, but also to replenish in some regard. So basically, acetic fluid is and should be removed. And then alternatively, some consultants and some practices may have been updated around this, but some consultants may give less than 4.5% and less than 20% or 40 grams and using 4.5% of human albumin solution gives around 250 mils post parenthesis and 250 mils over 12 hours later for each 2 liters for each of the 2 liters or every 2 liters of acetic fluid removed. So generally speaking, laboratory practices and standard operating procedures around this may differ slightly. But generally speaking, some consultants may give less, may give more, depending on the volume of acetic fluid that is removed per liter, which is then sort of equated around per gram according to protein loss. And so generally speaking, consultants can actually implement their own sort of way to ensure patients have the appropriate human albumin solution required as and when, according to the acetic fluid volume removed. In preterm, a little bit about preterm infants as well. And preterm infants, it's basically one of the main thing is to improve renal output and reduce tissue edema. And again, in conditions known as nephrotic syndrome or focal segmental glomerular sclerosis or FSGS, where protein leaking is part of the etiology of the renal of the renal condition. In preterm infants, it's important to improve renal output and reduce tissue edema. So inappropriate use for human albumin solution, generally speaking, in sort of preterm infants, is basically where there's parenteral nutrition issues. Where parenteral nutrition is actually adequate, which it could be normal. Where there is chronic protein, when there's chronic protein loss, and generally in chronic protein loss in preterm infants, human albumin solution can be counterproductive, because generally speaking, in preterm infants, it's important that patients that patients have the appropriate nutrition through natural means, rather than relying on human albumin solution. So chronic protein loss would not be an appropriate sort of condition where human albumin solution is administered, or be in that regard. And chronically impaired, where there's chronically impaired albumin production, and what I mean by this is basically where physiologically or from a physiological perspective, there could be an underlying condition where albumin production is impaired. So it's inappropriate to use human albumin solution, in that it may remedy some of the issue in some of the protein, some of the the loss at that time, but then what can happen, which would be more detrimental, is that the patient's physiology could depend on that form of treatment, and it's not what physicians would really would want. And then there's then it's important to maintain albumin levels in critically ill patients, and so critically versus chronically is different. And there is some works about the use of the importance of understanding sort of renal health in critically versus chronically ill patients, and so it's important to maintain the albumin levels in critically ill patients, but at the same time know that it's inappropriate to use human albumin solution where it becomes sort of where the patient's condition becomes dependent on sort of prophylaxis around human albumin solution levels. And so to maintain albumin levels in critically ill patients is something that health professionals on the front line would have sort of an overview as part of their procedures as well. There are some complications, of course. Human albumin solution is generally a very safe product, and the components that make up human albumin solution are quite natural to the body, generally from a physiological perspective. However, at the same time, having, for example, too much so the components, as I mentioned, or the constituents, as I mentioned in one of the earlier slides in this audio podcast, I mentioned that, for example, there's potassium, there's sodium, there's citrate, and other components. Obviously, from a physiological perspective, everyone has a threshold in relating to these different constituents. So human albumin solution is a very safe product, because it has the constituents that physiology that systemically that systemically are important, but it is not associated. It's not associated with the transmission. And it is not associated with the transmission of any viral or bacterial infection. So when medicinal products are prepared from human plasma, however, infectious diseases due to the transmission of infective agents cannot be totally excluded. So this applies to pathogens of unknown origin. And so what this means, generally speaking, is that there are pathogens within physiology, from a physiological and from a general sort of a systemic perspective, that are not completely known about, and so generally the human albumin solution is prepared from a human plasma, which is innate, that being said, patients should not, in serious conditions, for example, as mentioned in the previous slide, patients are not to be should not be prescribed any sort of more human albumin solution than that is actually required, because it could cause a trigger in pathogens that are part of physiology, but can but also do more can be more harmful than anything else. And this also applies to those pathogens of sort of unknown origin, basically where there is where scientists generally may have some knowledge around these unknown pathogens, but not enough, because historically or retrospectively there may not be a lot of literature around some of these things, generally speaking. Now, there is the risk of transmission of infective agents is, however, reduced by a selection of donors, by a medical interview. So in one of the previous audio podcasts, I talked about how where blood is being donated, for example, or where blood is donated to those recipients who might need certain blood donations in order to sustain aspects of their physiology. Generally speaking, there's a selection of donors and blood through a screening process, as part of a sort of a screening process by medical interview at these donation sites. Then there's also screening of donations for things like HIV or HCV and HBV, for example. And then there is testing of plasma pools for HCV genomic material as well, and there is a process where there is removal or inactivation procedures that are validated using sort of model viruses which are considered effective for those effective for those who are HIV, HCV, and HBV positive, for example. There are also two pasteurization procedures two pasteurization procedures. Pasteurization is effective against enveloped viruses such as HIV, HBV, and HCV, and some non-enveloped viruses, included hepatitis A virus. Now, there are some complications with human albumin solution as well. So patients can actually get a condition known as hypotension, which is low blood pressure. They can get a febrile reaction where basically they have fever. They can have fever-like reaction, and they can have urticaria, which is basically a condition closely relating to itching or scratching, and so complications with large doses, particularly around 20% human albumin solutions, can be identified as basically where patients can have pulmonary edema, so they can have swelling around the cardiovascular system. They can have high blood pressure as well, and some of the contraindications include hypersensitivity to albumin, human albumin solution. So patients who require human albumin solution may have high sensitivity to the infusion of human albumin solution, and hypersensitivity to some of the components that make up the human albumin solution, and also one of the main issues or concerns, because where human albumin solution is needed or required, it is actually where a patient, for example, who might have anemia, have a low hemoglobin, but then also because of potential component loss through blood, through hemorrhaging, for example, patients would automatically have hypovolemia, which is a low volume in particular, low volume of particular components that make up not just red cells, but also in plasma. So basically they could have decompensated cardiac insufficiency, they can have a high blood pressure, they can have esophageal varices, basically where there are sort of openings that normally wouldn't be within the stomach, for example. They can have sort of crevices or varices that open up because of the effect that human albumin solution has or can have. So there's esophageal varices, and there's also again there's pulmonary edema, There's hemorrhagic diatheses. So diatheses relates to where there is a stress on physiology, on general physiology, owing to the loss of blood, and also obviously severe hypovolemia generally also, from a physiological perspective, can relate to and does normally relate to severe anemia, where there's where the hemoglobin has been lost, is reduced. And then there is renal and post-renal anuria, or there can be renal and post-renal anuria, where basically the kidneys, the renal function can unfortunately shut down as a reaction to hemorrhagic diathesis, or through blood loss. And that's where I'm going to draw this audio and podcast to a close. As in the previous audios and podcasts, I have highlighted a few references and acknowledgements, and I am going to highlight them here again. So there's the International Society of Blood Transfusion, the Science series again, that was from 2020, and it's a special issue, and it was an introduction to blood transfusion from donor to recipient. And then there's an acknowledgement to Malcolm Needs, who is a transfusion scientist and practitioner in the United Kingdom for the approach to hematology. Acknowledgement to Professor Ken Jones, who's emeritus professor in immunology in the United Kingdom for the immunology perspective, and acknowledgement to Julie Mulloy, who is a teaching and learning scientist for healthcare professionals, and consultant at NHS blood and transplant in the United Kingdom. So the next audio podcast, and there's 3 more audio podcasts in this particular series. The next one will be about the ABO group, the ABO group system, or blood group systems, the immune hemolytic anemias, and then antibody screening and identification, and then in later there will be more collaborative audio podcasts with hopefully the renal patient support group, the RPSG, on another set of topics. But for now, I'm going to say thank you for listening, and I hope this has been informative, and feel free to use the timestamps to take any notes if and when needed, and any questions, then feel free to message accordingly. Thank you for listening.